A 46-year-old male with prior history of Ross procedure presented with end-stage heart failure with an ejection fraction less than 20%, severe aortic insufficiency, and proximal aortic aneurysm disease. He had a very high sensitization, and heart transplant was not deemed an option. A destination therapy strategy with reduced sternotomy, HeartMate 3 LVAD implantation, aortic valve replacement, and ascending aortic plus hemiarch reconstruction was planned. Perioperative chest radiography is shown, demonstrating prior sternotomy changes and high cardiothoracic radio. Highlighting imaging anatomy, we can visualize an enlarged cardiac silhouette with dilated cardiovascular structures. CT imaging is reviewed, allowing better visualization of the surrounding structures and confirming the pathology. The ascending and proximal aortic arch aneurysm is identified, guiding operative planning. Exposure of the right axillary artery is performed for arterial cannulation. A longitudinal midline skin incision is made, followed by radio sternotomy. Extensive lysis of adhesion is carried out. The innominate vein is identified and controlled. The driveline site for the HeartMate is created. Pericardial disease sutures are placed to improve exposure. The right atrium is cannulated for venous drainage. A left ventricular band is inserted from the apex for decompression. The ascending aorta is cross-clamped, the aorta is open, and the diseased aortic valve is exposed. Cooling is continued to the target temperature, and cardioplegia is delivered directly into the coronary ostia for myocardial protection. Sizing of the aortic valve is performed. The innominate artery is clamped into preparation for circulatory arrest. Systemic circulation is arrested to permit safe and arc reconstruction. A Dacron graft is used to create the open distal anastomosis, reinforce the Teflon felt. The graft is clamped proximally, trimmed to the desired length, through the air, and used to restore circulation. While rewarming is started, attention is turned to the proximal aorta, where intraoperative sutures are placed circumferentially around the aortic annulus. The bioprosthetic aortic valve is seated and secured into position. The conduit is trimmed to the appropriate length. The conduit is anastomosed using a running 4O proline. Sutures are placed for the aortic root band to facilitate the airing. The conduit is unclamped and flow is restored. Attention is then turned to the LVAD implantation and the apical sewing cuff is positioned. The cuff is secured to the left ventricle apex. The ventricle is core and the HeartMate 3 inflow cannula is implanted. The outflow graft is measured and tailored to the appropriate length. A partial occlusion clamp is applied to the conduit. The LVAD outflow graft is anastomosed to the conduit with reinforcement using a pericardial patch. Following the airing, LVAD support is initiated and the patient is weaned from cardiopulmonary bypass. Given the complexity of the case, the chest is selectively left open for delayed closure using a S-mark membrane. On postoperative day 1, the patient had no acute overnight events. Postoperative chest X-ray demonstrates successfully chest closure and appropriate LVAD position. Thank you for watching. For more cardiovascular and vascular surgery educational content, please subscribe to the Houston Methodist DeBakey CV Education YouTube channel.